my name is Martina Porter. I'm a dermatologist at Beth Israel Deaconess Medical Center in Boston, one of the Harvard Medical School affiliated hospitals. And I'm also, as I said, a dermatologist, but I specialize in HS care and clinical trials. And I'm our vice chair of research and academics as well for our Department of Dermatology. So acne was the most common treatment adverse event in this trial. Is about just under 20% of patients overall. And the interesting part was that there was no dose-related issue. We thought maybe at the 12-week mark that the higher dose had higher rates of acne, but actually when you look out to 54 weeks, the two groups had about the same number of patients with acne. They did actually grade the severity of acne for this trial, and it's nice to be a dermatologist doing a clinical trial because we know we can actually trust their severity assessments for a skin condition. And almost all the patients were mild with a few moderate patients for acne, but there weren't people who developed large cystic or severe acne reactions and needed to be discontinued from drug. The other thing to note for clinical trials is that acne and HS overlap a lot in what we're able to do for treatment for them. And so in clinical practice, for a patient who has persistent acne, we might start with topical treatments and then transition to oral antibiotics or to isotretinoin. But in HS clinical trials, we're actually limited in our ability to do that because all of those medications can potentially impact the HS efficacy outpoints. And so they're all prohibited by the clinical trial itself. And so patients weren't able to really fully get full acne treatment. And so it's a little difficult when you look at a data set like this to know like what would have happened if we were able to treat them adequately, which is what we'll be able to do in real practice. My personal experience with JAK inhibitors in HS is that JAK inhibitors do cause acne across all different populations. We've seen it from patients who take them for atopic dermatitis or alopecia areata. I see it a lot with patients with inflammatory bowel disease, and the patterns are very similar. They mostly get like milder lesions and a hormonal distribution. But the interesting part, I think, about HS is that we're also looking at a subset of patients that are different from these other populations because HS mostly affects younger females, and they're the ones who are much more likely to get hormonal acne. So to me, it wasn't really that surprising to see a lot more acne in this population potentially than some other patient populations. And this is the first very large phase 3 trial we finished for JAK inhibitors in HS. And so I think we're just seeing a combination of the medication causes acne, which is not unexpected for a JAK inhibitor, and the patient population is at much higher risk of getting acne. But I've been very successful in my clinical practice being able to treat patients with the same acne sort of paradigm that we use for patients who don't have HS and who aren't on JAK inhibitors. I touched on this a little bit earlier, but I think it was about a third of the patients, just under 30%, had actually been on biologics before entering the study. And I don't believe it was in this Nature publication, but at one of the recent conferences, they actually did an analysis of patients who were biologic exposed prior to entering the trial to see what their efficacy endpoints were. And actually, the patients on biologics previously who had already failed or stopped taking them for whatever reason and then went into the trial did just as well as patients overall in the trial. And that might sound like, yeah, whatever, but actually it's a big difference because those patients, when you look at their baseline severity, they had a much higher lesion counts and their disease was worse, but they were actually still able to achieve the same type of endpoints that a bio-naive patient was or one who had never taken a biologic. And so to me, it suggested that, here's a really good treatment option for patients who may have already failed one of these other biologic medications because TNF alpha and IL-17 inhibitors are actually not that far apart in terms of like the pathophysiology that they're targeting from the disease, whereas JAK inhibitors, specifically JAK1 selective, target different pathways and may really make a big difference for some of these patients who didn't have a great response to other therapies. And then I think it also, for most treatment refractory patients, opens up the door potentially combining therapies since, like I just mentioned, JAK1 selective and IL-17A, for example, have very little overlap. And so you may be able to hit both of them if you're able to get them approved, for example, on some of our most severe and refractory patients. And then I think for patients in general, especially in a younger population like HS that's a little hesitant to take medications, having an oral option and one that you can start and stop that doesn't have as long of a half-life can actually be something that they're really welcome to the idea of, because it seems like a less of a big step for them to jump into getting an injection, especially one that could be every week or multiple pens every week. And so I think what we'll see over time is we'll have a lot more different options for treating HS, and hopefully we'll come up with better ways to identify earlier on how to do this like precision-based medicine where we're really giving people their best treatment option at the beginning. But I think that still requires a little work and more medications, I think, to be available for really be able to discern between the populations. We'll learn a lot once the medication povorcitinib actually comes to market, and we'll be able to try it in different patient populations. And we have other JAK inhibitors that are already FDA approved for, as I mentioned, different conditions. And I've actually used quite a few of them over time in different patients. And what I've noted, which is not data that, or the types of data that we capture in clinical trials, is that I actually think there is there's two populations that really benefit from JAK inhibitors in HS, and one is very similar to these Crohn's patients that we see that have horrible tunneling or a lot of fistulas in the groin area and in the buttocks, and they're those patients that sit down on the bed and there's just like pus everywhere all over the table. Those patients actually do pretty well on high dose JAK inhibition, and it may be that they're more like a Crohn's phenotype, which is also has many JAK inhibitors approved for it now. And then also on the complete opposite end of the spectrum are people who have a lot of nodules, but they don't really make tunnels over time. And it's very long-standing history of the disease, and maybe lots of females in their family have a similar presentation. Those patients also do really well with JAK inhibition too, but they're probably not patients that people are automatically thinking that they need to be treated with systemic therapies because they're milder. But I do think it'll be important as we move forward with treatments to start treating earlier and to treating people before they get scarring and tunneling. And maybe this medication will really have a big impact on those patients in what we now like to call the window of opportunity to try to halt their disease before it gets worse.